We don't have time for formal introductions, but just by virtue of our title, obviously we have medical providers that are in attendance today. We also have other persons and professionals that work in healthcare settings. That's great, but I also wanted to brag a little bit in the fact that we also have widespread participation from the broader community that has become attracted to today's discussion. So not only do we have medical providers in attendance and those who work in healthcare settings, but we also have faith leaders in attendance, educators, military, law enforcement, mental health advocates, volunteers, representatives of elected officials, and numerous community-based organizations. Believe it or not, we also have our partners from outside of the county representing Orange County, Riverside, San Bernardino, and also Imperial counties. So once again, welcome and thank you for being here. It's really good to have the whole community involved because as we say at the San Diego County Suicide Prevention Council, suicide prevention is everybody's business. Secondly, I'd just like to acknowledge the fact that in San Diego here, we have an extremely competitive healthcare environment, don't we? I don't want to discount that one bit. But if there's anything that I know about San Diego after all of these years working in this community is that when it comes down to it, we know how to collaborate. And that's what today is all about, right? Collaboration. And I'm hoping that the spirit of collaboration that is unique to San Diego, the way that we check our agendas at the door and pool our talents and skills and resources for the greater good and optimal health for all in the community is exactly where we're going. And I'm hoping that the suicide risk assessment discussion today will move us forward in terms of suicide prevention on a policy and systems level in order to fortify our mental health system landscape. Third, I'd just like to acknowledge the fact that, believe it or not, we've spent the better portion of 2 years trying to get today to this discussion. 2 years. The journey has been very long, but also insightful and educational. I'll admit, a little bit stressful too. But I just want to thank everyone here today for lending their guidance, their wisdom, their talent and skills, bringing us to today's event. And more than anything, I just wanted to thank folks that have been our advisors along through this process and the people that are here today. Thank you for trusting our organization. Thank you for trusting our council to create a safe space for a very important discussion on suicide risk assessment, which I hope moves our community forward together in the spirit of collaboration. So with that, I'd just like to acknowledge some of the sponsors for today's discussion. County of San Diego Health and Human Services Agency, Behavioral Health Services Division, Kaiser Permanente, University of San Diego, Scripps Mercy Hospital, and also my employer, my team's employer, Community Health Improvement Partners, CHIP. So with that, let's make it a great day. I'd also like to, at this time, acknowledge my colleague Beth Seiss, co-chair, San Diego County Suicide Prevention Council, also representing Scripps Mercy Hospital. Beth will speak to our opportunity for improvement. Thank you for being here.
So suicide in San Diego, it's an alarming reality. We've had some fits and starts with this subject. We, as a council, have worked together in one way, shape, or form for at least 15 years. I don't have wonderful news on that topic. Historically, in San Diego, we've tracked more or less over the years rates of suicide per 100,000 population that have been similar to those of the national statistics in blue. We're the green, as you can see. And while we don't have more recent data for national statistics, you can see that we have increased yearly for a number of years. Historically, we've been 20% greater than the state overall. And while the state recently has had a downtick in suicides, not so in San Diego. We last year had 441 or so suicides for that calendar year and 2013. And we'll be updating our data. You have in your packets our report to the community, and you have more detail on this information therein. Suffice it to say, suicide is a major problem public health problem in San Diego. It's the highest ever, and we need to do something about it. In our report to you, we have, in a nutshell, some changes from year to year, and we aim in our next annual report to do similar analyses for you. Our negative direction changes, again, up 3 years in a row, not good news. Self-inflicted injury in our EDs, discharge rate is up 11%, and that's a measure of non-fatal attempts. And our QPR trainings recently are fewer. That's question, persuade, and refer, something that CHIP offers to the community, and I recommend it to you. We're aiming to increase that. The positive directed change, we're also tracking self-help measures in our county. Crisis calls to our wonderful Access and Crisis line are up, as well as our Up to Us media campaign, which I recommend to you. Those are up dramatically. So self-help measures are improved, but we have a big challenge ahead of us. So our goal here today is to promote the use of evidence-based screening tools for suicide risk assessment. Suicide is preventable, and with timely intervention, we know that screening and other measures, case finding, if we target to the right folks at the right time, we can meet this challenge bit by bit. So today we aim to review local current practices in the area of suicide risk assessment, examine tools that we have in place for this purpose in our region, and preview in particular the Columbia Suicide Severity Rating Scale. This is an evidence-based scale in wide use, and we aim to learn more about it with our presenter today. Our presenter is Dr. Kelly Posner. She is founder and principal investigator of Columbia University's Center for Suicide Risk Assessment and a board member of the AFSP, American Foundation for Suicide Prevention. She was commissioned by the FDA to lead a study to develop improved methods of suicide risk assessment, which have been recommended or mandated across many areas of medicine.
I would like to introduce myself. I guess I'm a man who needs no introduction in Dana's eyes, but I am Nicky Fantides. I happen to serve as the Chief Medical Officer of the County of San Diego and will be serving as the moderator of this panel. Before I get started, I want to acknowledge a couple things. First off, how much we, the county, appreciate the effort of the Suicide Prevention Council, and I especially want to give props and thanks to my brother Dana and his staff for putting today on. As was mentioned, I work for the county, and I am a proponent of the county's current strategy for health and wellness in our region we call Live Well San Diego. And it's interesting because one of the privileges that I have as the Chief Medical Officer, frankly, is trying to integrate what we ourselves do within our vast entity, okay? From a health perspective, for example, you can just look at things from the behavioral health perspective or the public health perspective or the physical health perspective. We have a ways to go ourselves in terms of integrating ourselves as an agency at the same time that we are promoting that kind of horizontal, collaborative, collective impact type integration in our communities. And one of the privileges in my role is having the opportunity to be a participant on behalf of the agency in many of the collective impact initiatives that we have in our region, whether it's childhood obesity or the Be There initiative to decrease and actually eliminate heart attacks and strokes in our regions, to the Alzheimer's initiative, which is taking up and picking off a lot of steam in terms of bringing best practice efforts between all the different medical groups and care groups in our community with regard to that very challenging and growing population. Decreasing readmissions to hospitals. There's so many efforts, HIV screening, there's a lot of these things. And one of the blessings of being part of some of those efforts is that you kind of get to see some fruit in the sense that there are some impacts. And there's some of the chronic diseases and things in our community that we're working on that we see decreasing trends with. With suicide, as you've heard today, both locally and at a national level, that's not a reality that we can yet lay claim to. And it's with that spirit of authenticity and appreciation that we are here today to talk and to build upon the opportunity that we have to better align and coordinate and perhaps even standardize some of the things that we're doing in our own community. Dr. Bruce Haynes. Dr. Bruce Haynes is the Medical Director of Emergency Medical Services with the County of San Diego Health and Human Service Agency. And Bruce, would you mind, as we start off, just give a quick synopsis? What exactly is EMS so our audience?
Sure, Nick. We coordinate the provision of emergency care, so EMTs, paramedics, licensing. We license ambulance companies, the specialty hospitals like trauma and stroke and heart attack, and a number of things like that, also having to do with disaster medical services, so that, for example, in 2007, we evacuated a number of hospitals and nursing homes. So that's kind of what we do.
Thank you, Bruce. And in the context of that, could you please talk a little bit about the potential or the reality of the field assessment for suicide risk with regard to EMS workers and that workforce, please?
We have not had a lot of trouble with that, like missing patients or leaving them. I think the system works pretty well, which is remarkable because paramedics and EMTs don't necessarily get a lot of initial training on this subject and in behavioral health in general. There's so many things they have to learn that that's kind of been pushed back. Last night I went through one of the main paramedic textbooks, and there's 6 volumes, 6 different books, and there was 1 page on suicide. So I think it's blended in other parts of the book as well, but still they have to really learn as they go along as well. And I think they do a good job.
Good morning. The Council of Community Clinics is a support and advocacy agency to 16 different federally qualified health center organizations here in San Diego County. Those federally qualified health centers operate about 90 to 100 sites here in San Diego County, and we offer support to them through managing their IT systems, purchasing products in bulk for them, and also centrally managing various grants that they have, and finally providing some advocacy on their behalf to folks in Sacramento.
And Marty, realizing that about the current experience and reality with regard to suicide risk assessment, if it's happening, and if so, what tool is being used?
So I'm going to answer the last part of your question first. Maybe I'm going to be a politician when I grow up. The tools that are mostly being used these days are the PHQ-2 and PHQ-9. So I was really interested and talked with Dr. Posner after she spoke about how to sort of integrate her tool into kind of what's happening right now. But let me backtrack and say I've been in this position for about 7.5 years. And in that period of time, there's been tremendous growth, or significant growth, I think, at the FQHCs with regard to screening in general. So we've made some pretty significant improvement in being willing to screen initially for depression, and now in a lot of cases for anxiety. So it's fairly common in most of the clinics that these kinds of screenings are being done on a regular basis.
Yeah, North County Health Services has a whole menu of different types of services. They do HIV case management, primarily primary care, pediatrics, dentistry, really you name it. We've got a WIC program.
What are you doing with regard to screening? How routine is it? Is it standardized and so forth, honestly?
We'll start with the C-SSRS wasn't something that the primary care folks felt comfortable with. It was for them to direct. And I think in primary care, it just didn't provide them with something they could treat. At least that was their perception. And so we went with the PHQ-2, PHQ-9, and then I insisted that we add the GAD-7 for anxiety, looking at hopelessness and anxiety. They're really good predictors for suicide. And so the primary care staff has become comfortable using those. They ask the PHQ-2 and the general anxiety questions on everyone, all the way down to 13 years, and then we've got some different things that we're working on for kids younger than that. But then we use the 9 and 7 screening tools, and that's where behavioral health comes in, is whenever they move on to that next level, they'll contact us and we try to go in same day and kind of do the warm handoff and do a more in-depth screening. You know, I think that the biggest challenge that federally qualified health centers and really any community clinic is having, I know that we had the same problem in Indian Health, it is there's no place if somebody doesn't necessarily meet that threshold where they need to go to the hospital, but they really do need services. We can't seem to provide access, you know, within a week, which would be reasonable. And right now, I think that, you know, we're out to 4-6 weeks sometimes to get somebody in to see a therapist.
Yes, I'm the Director of Operations of our emergency department at Scripps Mercy. We see about 60,000 patients a year. We're a trauma center and academic institution. And I also chair the Emergency Medicine Oversight Commission. We meet on a monthly basis. Dr. Haynes comes to those meetings, and we bring together all 21 emergency departments and to discuss how we can make care better.
A little bit about what you're doing in your emergency room as far as screening and training and standardization, please.
So the first question about screening tools, I think the first question when you come into any emergency departments, have you been to West Africa? And after that comes domestic violence, tuberculosis, and suicidal ideation. So we screen on a routine basis. We've had some instances in our emergency department, and I think all the ERs in town ask about suicidal ideations. It's part of the checkoff list. We don't do it in a standardized fashion, like Dr. Posner's did, and there's a lot of good ideas now flowing in my head of how we can bring that standardization. But we definitely ask about suicidal ideation. And Dr. Seymour mentioned earlier in his question, the word kind of gets out because we asked, are you suicidal? And then it seemed like everybody that day said yes. We had a little
when it's
ding.
cold and raining? Or?
Yeah. We had a ding from Department of Health Services and said that, okay, from now on, anybody who's suicidal needs to have a constant observer. And at one point, you know, nurses, techs, we had more constant observers than nurses. And the word got out on the street, just go to Mercy and ask for one of those constant observers, because they sit with you and they give you food and a blanket, and it's like, I want one of those.
So the VA is a national healthcare system that's dedicated to veterans. Not all veterans are eligible for VA care. Generally, you have to have an illness or injury related to military service, served in Iraq and Afghanistan, or below a certain income threshold.
The VA's approach to screening, and kind of give a summary of what's happening with regard to suicide prevention.
Sure. Let me start with the second half first, and screening. So we have sites of care throughout the county in Escondido, Oceanside, Mission Valley, Sorrento Valley, Chula Vista, then in El Centro and Imperial County as well. In primary care, we do a screening with primary care, so that's part of their annual evaluation. For veterans that screen positive, and there's a number of triggers for that, they get a complete assessment. One of our suicide prevention coordinators are here today, and our assessment's very similar to the assessment that was presented this morning, which is good to hear. And then if they score moderate or high on that assessment, we have 3 suicide prevention coordinators that actually are intensely following those veterans. And we have right now, I think, about 180 on that list. that get close weekly checkups on how they're doing, and really, again, intensive case management because they are vulnerable.
San Diego. Thank you for having me, everybody. I'm George Sclary with Community Health Group. I've been there for 23 years. Community Health Group is a local not-for-profit Medi-Cal managed care plan and Medicare. We've recently moved into the Medicare line of business. So we are the largest of the 5 Medi-Cal managed care plans. Those plans are Community Health Group, Care First, Health Net, Molina, and Kaiser Permanente. And we've been around for 33 years. It took us till probably 2 years ago to reach 100,000 members, and we are now at 230,000 Medi-Cal members, if that tells you what's happening in the world of Medi-Cal right now. Right. And a lot of this is has to do with a lot of things, especially the Affordable Care Act and Covered California. A lot of people are not qualifying for Covered California, but now qualifying for Medi-Cal. You no longer have to be just poor and disabled or mom on welfare with babies to get Medi-Cal managed care. You can be a childless adult and be working but have a limited income. So it's our world is just growing drastically. Since 1993 when I started, I've been overseeing behavioral health services for Community Health Group.
I ask you, what is the role of a health plan with regard to screening for suicide risk?
It's a good question. A little bit hard to answer because a health plan is not a provider. We don't provide care, we pay for care. So we have systems out there and we're all a little bit different. Kaiser's a Medi-Cal health plan, they're incredible, they have their system. You know, the other 4 health plans do things a little bit differently. Some of them have a simple number to call, so I'll talk more about that because that's what my health plan does since I've been around since 1993, which is an 800 behavioral health number. And calling that number is going to reach somebody with behavioral health experience and degrees, not necessarily licensed clinicians. But
can I interrupt you, George? Is that a standard, or is that something that you do?
It's something that I and a couple others do. You know, so I prefer it that way instead of calling a customer service department that you're actually getting a behavioral health department. But the other health plans, you know, have customer service departments that will take a call, and if somebody is saying, or, you know, coming right out and saying they might do something themselves, they know and they're trained on what to do. Our partners at the San Diego County Access and Crisis Line run by Optum Health, you know, we do warm transfers over to them and stuff. The ones like my health plan that has behavioral health staff on site, taking a direct 800 number, you know, we're not really there like I think a lot of people think, which is to do a big screening on the phone to kind of stop people from getting the care they need. It's really the opposite. I always refer to us and myself as a glorified matchmaker, making sure that if somebody's calling and it's about a kid that maybe need Ritalin for ADHD drugs, they're, you know, and only speak Spanish, they're not referred to a non-Spanish speaking psychologist who can't prescribe drugs anyways. So it's really hooking people up and getting them the care they need and making sure they get the appointments they need. But when somebody does call and there's reason to believe, you know, if they're slurring their words and they're really nervous or anxious, or you start feeling like they're about to cry on the phone, you might ask a little bit more questions, and the health plans normally have access to a licensed clinician that would take over the call and or do a warm transfer over to the Access and Crisis Line.
Okay, so one of the things I'm really happy to see here as a member of the community and also a law student and with my personal background as a nurse, I'm happy to see that the community and healthcare in general is addressing this issue because I think that it is obviously a very big issue. But my concern is we're only really able to capture that group of the population that's actually coming in for services or that are being referred or that through self-help or other means are going there. So this leads to me to think that there is an obvious disparity between perceptions of healthcare providers versus the general community at large. So my question is have we done any like community-based participatory research or anything that like looks at widespread community knowledge, perceptions, and everything else to see if there's anything that we can be addressing at a community level before they even get to you guys? What do you guys think about that?
Anyone, I mean, I think I'm going to defer part of the answer to that question to my colleague on the next panel. We have been doing some pretty aggressive, broader outreach to our community. You may have heard of It's Up to Us in terms of taking it, if you would, outside the walls of healthcare delivery. We have a whole campaign related to that issue. It's not adequate, but it's being attempted and being pursued. A lot of that appealing, by the way, not to the individual themselves, but to those around them in terms of some of the sites and concerns and red flags to be looking for. And more, and I will defer to Dr. Karlstein, who will probably make some comments about that during the next panel. But did any of you, Jeff, did you want to make a comment, and then Leon?
You want to go first?
No, go right ahead.
So this is very important with the veteran population. There's two significant initiatives that have just happened on this. One is that we have partnered just recently with CHIP to do QPR training, which is question, persuade, respond. And last week we had 30 people in our facility trained on that awareness training, not just for VA, though we had folks from the VA there. We had folks from the community, from 211, from CHIP, from other agencies there. So that's train the trainer, because the idea is that we would host that training or others would host that training as a way to get the word out. So the second thing is so you can't tell anyone outside the room on this. And I'll tell you why.
Seriously?
Well, so
It's a secret.
I was at a meeting yesterday. There's an initiative we've been working on as a community for in San Diego for the last year and a half that was called MTSP. Now it's called 0800. And what it is doing, we just started this, is as those that are separating from the military, they're connected with a navigator, which is a social worker. Now, it's an opt-in program, but they're connecting the veteran at 2 weeks, 3 months, 6 months, and then a year. And the beauty of that is they're connecting them just in general. So there's a lot of precursors to someone who goes in at risk or doesn't have resiliency for suicide. So loss of job, loss of spouse, homelessness. But that's the entry to talk if they are really seriously thinking of, harming themselves. It's just started this last month and being rolled out. I'm very, very optimistic about it. It's community collaborative based here in San Diego. Why I keep this among the community is because I think nationally they're clamoring for something like this. And again, San Diego is being on the forefront of doing something locally that really could benefit nationally. But I do think that, we just talked about it yesterday, that endeavor needs some space to mature and to really get up and ramp up before people from Washington or other areas come in and say, we want to do it in our location as well. But I think that has a lot of potential, exactly what you're talking about.
Thank you. Leon, did you want to make a comment?
I think that it's a good opportunity to point out that Dana Richardson and Yenny Palomino and Elizabeth Vaughn with Community Health Improvement Partners have been really driving this for years now. Through connecting QPR with the community, I think, over 8,000 people have been trained in QPR screening and the question, persuade, and refer. I think it's an enormous start. The It's Up to Us campaign has been big. CHIP actually organized with the southern 5 counties in California to put together a best practice that was submitted to the Suicide Prevention Resource Center. It was a Facebook campaign, just a social media campaign for suicide prevention.
My name is Mike Seiss. I'm the trauma surgeon in more than just behavioral health terms. But I'm here because of the incredible impact of mental health issues related to injury that's not always fatal. And on my service right now at Christ Mercy Hospital, I have quite a number of patients who attempted to kill themselves and failed, fortunately. Many of whom had completely unheralded self-harm with absolutely no indicators, but a variety of things that lined up, not unlike pieces of Swiss cheese that line up and you can see straight through sooner or later. As we start to talk about what it'll take to implement a tool like this one, we're not here to endorse this tool, although we'll talk a little bit about how promising it appears. I would remind you that in the last 3 years we measured, our rate went up by 18%. 18%. So as you look out at the members of your family, your community, your school, one of the top 2 causes of them dying needlessly from non-natural death is self-inflicted harm, is suicide. Now, it just so happens that the other one is prescription drug overdose, which is huge. So not only should you think about how we can ask everyone in our community the important questions that will identify their risk, frequently a temporary risk, not a lifelong risk. Many of us in this audience are dealing with people who have malignant behavioral health issues. The maybe 1%, maybe 5% in certain populations. What about the 95%? And just briefly, I was talking with my friend and colleague, Dr. Michael Ichiyama, who is the chair of the psychology department on this campus. I happen to be an instructor in psychology, along with Dr. Steve Shackford. All my friends want to know abnormal psychology. But we have a program with pre-med students where we introduce them to compassionate and effective communication and the physician-patient relationship. And we were talking about the fact that on this campus, we're not screening the students on this campus, and yet they're a high-risk population because college age is a high risk. So as we talk as a panel, I'm going to ask our panel members and invite you to ask, how do we reach out to the entire community? I'm proud to be everyone's colleague in this room. Everybody here is trying to make it better for the community. So I'm going to be asking our panel members to kind of take a step outside of their community perspective and look at how we reach out with colleagues like Michael Ichiyama to screen an entire campus of students who are at risk, or how we work with Ronit Lev to screen everybody who comes to the emergency department, or at the community clinics, because the evidence is clear. Between the schools and healthcare, we can reach almost the entire population this year if we adopt one promising technology in terms of screening. So I'd like to ask my friend and colleague Stan Collins, who's been at this a long time in instructing the community members on screening, what would it take? Let's say, Stan, we said, okay, we like this tool. Okay, it's promising. Nothing's yet completely proven, but it's pretty promising. How would you roll it out, given your on-the-ground experience?
So the question was, how would we roll this out? How would we get this screening tool out there? I think a lot of great points have been made today, but I think one of the most powerful ones is come back to general awareness. The young lady, Jennifer, I believe, asked a question about, okay, well, that's great if the medical providers are prepared, but how do we get them there in the first place? So I think between the Up to Us campaign, one thing that kind of got glanced over earlier when we were showing our report to the community was that our help seeking here in our community has gone up tremendously over the last few years. The Up to Us campaign, it started, I think the first year had about 50,000 visits, and over the past 3 years, I think last year they had 98,000, or I don't know, it's tremendous, the amount of visits they're getting to the website. The calls to the Access and Crisis line are increasing. So people are beginning to access the resources more. So I think the message is starting to get out there. But one of my messages that I think you kind of just echoed was, I always, as much as mental health and diagnosis and treatment happens in the clinical setting, I think a lot of times people forget that suicide prevention happens, or begins at least, with friends and family. And getting that education first to them so that they're educated with the warning signs and the risk factors. And then I think another piece of it that we touched on today was, it's one thing to have these great tools, but if the provider in the room isn't comfortable to say the S word, then what good is the tool going to be? And so I think going back and getting them just the basic, when I walk into a room and I give a training on QPR, whatever the curriculum is, I tell them that I'm not there to make them a psychologist or a therapist, that I'm not none of those things, but that I'm there to make them, if they walk out of that door more educated and more comfortable with the subject, then I've done my job. So,
but Dr. Michael Krelstein, you've had a lot of experience with screening. You have a intensely at-risk population. Stepping outside of that perspective, how do we reach the entire community with, we're sort of looking at a marketing business plan, if you think about it. Not everybody's going to buy Starbucks, but gosh darn it, Starbucks is everywhere. Well, on the other hand, maybe we're looking at a Keurig type model. I don't know. How do we reach as many people as possible, knowing that we can't get to 100% of the risk, but how do we have the best return on investment out there in the entire community? not just our therapeutic communities with behavioral health patients?
Well, that's a terrific question and a tremendous challenge, of course. And we, I think, have begun to fill in that answer with some of the efforts that we already have through CHIP and the Suicide Prevention Council and all of the work groups that they're connected with, as well as the tools that we've already been discussing here amongst the panelists. But I also just want to, I guess, add one word of advisory caution, because the need is tremendous. The opportunities and the suffering and trauma that can be prevented has to be responded to. But there's also only a certain amount of bandwidth. There's a certain amount of resources. We need to also, I think, include as a counterbalance to the larger picture, focused efforts. And so there was a comment earlier about, how do we, similar to what you just asked, how do we get to the outreach, how do we do outreach to the outlying communities? But at the same time, we have to recognize that, in fact, when we do psychological autopsies on completed suicides, 40% of these individuals have seen a primary care provider in the last month, 70% within the last year. So that is a concentrated population of people that we really need to also keep our eye on as we try to increase our outreach to the outliers.
Dr. Allison Hadley, at UCSD, you're really one of the safety net providers, and the front line of the safety net is the emergency department. How do we sort of use this in an emergency department setting?
Well, I think in our emergency department, we do, I think the same as Dr. Lev said, a screening with our triage nurse, and they ask 2 questions. They're not the exact same ones as Dr. Posner's screen, but they're 2 questions, and that causes an alert to go to the doctor if there's a positive screen, and that causes them to have an increased level of observation in the ER. So I think we're pretty good at screening, and then if there is concern, a psychiatrist will see the patient and do more screening and more risk assessment. I think we do a decent amount of screening and risk assessment and are able to stratify risk. One of the main issues we're having is what to do next.
Dr. Ralph Johnson, at Kaiser, Kaiser's been really out there and talking about prevention and the messaging about health and what you need to do. So can we do this thing? If we decided, let's just say we decided, okay, we like this tool.
Can we?
Yeah, how would you do it? How would you do it?
So from the standpoint of implementation, especially with kind of as robust system as we have, we briefly talked a little bit about using electronic records and things like that. And that's kind of a new and upcoming thing, and certainly it's going to become a bigger and bigger role, especially in the community, is using those electronic resources to reach people, but also the ground force where you get people seeing the primary care doctors, and the primary care doctors or the medical assistants, the LVNs, or whoever they're first contacting, using those new means by which to gather that information, capture it, and get them to the right people. So I'm very interested in any process that not only streamlines it, but provides it to become a more efficacious process where you do get those, you get rid of those false positives, and you get it to where the resources are allocated in the right ways. So in implementing it, I think it's very important that that we start using the medical records, that the screening is captured, put into there, and then that's then moved towards the mental health professionals, or if it doesn't quite meet that tier, that it's getting to qualified therapists or qualified counselors that can certainly deal with these individuals. Again, we have a pretty robust system. We have a very large population, and trying to get everyone screened is actually a pretty effective thing. We do that with PHQ-2s. When people are coming in on routine visits, that's usually done at the front office with our one-to-one staff. And this brings up, the conference does bring up an interesting question or problem perhaps in looking at that 9th question on that PHQ-9. Really, how valid is that question? Is that an appropriate question we should be asking? And that actually allows me to kind of go back and look at my medical group and say, how can we maybe change what we're going to do to move forward and produce better questions to lower the false positives and move towards getting better capture of these people and get them to the right people.
You're involved with outpatient services, and you're dealing with a behavioral health community primarily, but how would you implement this in a outpatient service? In other words, how would you get it to be standard of practice, standard culture for your providers to be doing this kind of screening? Now, granted, you have an at-risk population, perhaps more than the general population, or not. You know, we still don't know that for sure. But how would you implement this if we decided on a tool, a simple tool we're going to use? What would be sort of the metrics you would put into it? How would you track it? Because work not documented is work not done.
Right. That's a great question for me because we're actually actively working on this in our outpatient programs at Sharp Mesa Vista. What we recognized is that our current...
The C-SSRS specifically, right?
Correct.
Could you elevate the mic just a bit so we can hear you? Great.
Oops.
You can take it right out if you want.
We started off looking at our previous assessment and screening tool, thinking that the problem was we just weren't completing it with enough quality, that it was really more of a task, something that had to be done. People were checking it off. It wasn't leading to any better intervention or better identification of the percent of people in our outpatient programs who truly are at the greatest risk for suicide. We found actually, I think in our anxiety to create a better and better homegrown tool, that we asked so many questions that almost 90% of our people were getting ruled into the full assessment from the screener. So as we started to look at this, we came to the C-SSRS and are actively looking at how we can implement this tool to lead to clinical recommendations and interventions, to identify really the people who are in the top 10% of our outpatient programs that we already recognize and talk about amongst ourselves. These are the people we're calling the next day or that same day if they don't show up. These are the people we're talking in our treatment teams. What are we going to do? We're worried about them. We're talking about them. But they were, if you looked at their treatment plan, not necessarily that different than somebody who just had been ruled in and had maybe a family member who had died by suicide or something like that.
Well, Doctor had a checkbook for all of us in terms of more actual support. I will say, though, that Beth and I are proud that our son, Robert, who has an MBA and PH and his MD degree from UCSF, is a psychiatry intern at the University of Washington. So we've made our contribution to treatment. But how would you roll out this screening from your perspective?
I think we run the risk, like a lot of folks do, of fishing with a wide net. Where you captured everybody, and you're capturing way too many folks, that more than what your system can handle, and so we do run the risk of that, and I think that of course is preferable than missing some folks, but I think as far as rolling it out to the community, API is a system, and so we have a continuum of care ranging from clubhouse to outpatient services to inpatient, and so that affords us many opportunities, whether it's going to board and care type facilities, residential facilities, educating and partnering with other like facilities. We have outpatient services, which is a big deal. We have hundreds of patients that participate, and there's the Ambulatory Association for Behavioral Health, and so that's one way our participation on that level. We can share resources, and we often do. And so if there's a screening like the Columbia, that's something that we can certainly share and encourage, and we can talk about our successes with that. I think continuing to provide education to other folks in the community, other providers, other agencies, schools, skilled nursing facilities. So there are definitely ways to educate and roll it out.
Tell to effective screening the right sizing of who we refer. How do we do that? If not this tool, what some other tool? But how do we do it? This tool is attractive in the sense that it has the advantage of right-sizing referral.
If I may, so just kind of backing up a little bit to answer your question. I think the tool that's being proposed now, the suicide prevention tool, is I think that's a fine and dandy thing to be using. And one of the things that you have to realize is that, especially with healthcare in general, we're seeing more of a shift, and it is a shift from being reactive to the problem, the person's tried to commit suicide or has completed a suicide, to now being proactive and trying to prevent these things and looking for these things. This means there's going to be more screening for this. We're not going to be just reacting, we're going to be proactive. And in doing that, we have to have a tool. You're right, you have to have a tool that's in place, that's easy to use, that's easily trainable, that the education can be provided very easily. And then also the complexity of the tool can't be so much to where you have to have higher level medical care workers administering it, be used by most people. So I see this as potentially as a very helpful type tool. And in the broad realm of rolling something like that out, like I said, that's one, the shift has already occurred. Every medical group that's here already feels the pressure of we need to go towards prevention, not just react to dealing with the problems. And in doing that, that means they're utilizing the resources they have, which means they grow using their electronic means, they use their community outreach insofar as phone calls, insofar as meetings at their different medical groups or at their hospitals, to where they invite the community to come in, hear what they have to say, but also use it as an opportunity to reach out to them and say, hey, let me just ask a couple questions at the beginning, or maybe hand out a flyer and see if you could capture them, and use non-traditional ways. Maybe you're capturing them when they come into cardiology to, for their heart attack. These people have a higher incidence of depression than the general population. Or how about you do screening, not just for psychiatry, but also just in primary care, like we already are doing to a degree. So thinking outside the box is going to be really important, but also accepting and moving forward with the idea we've got to be preventative and be on top of things.
As you respond to that question, let me also remind all of you that we're undergoing what's called a silver tsunami of the aging population, and being old and depressed is not right. Just because you're old, you don't have to be depressed. Mm-hmm. And now one of the big bumps in the rise in suicide is in people my age. I'll be 65 this summer. It's a big rise in our elderly population, and yet I have a vascular surgery clinic that I run where most folks I see for life. I don't ask them those questions. I'm going to sure take a look at it now. But what about the rest of you? What about the tsunami of older folks who are prone to depression, who aren't being treated? Andrew, you...
Yeah, I was going to say, you talked about the collective groan. You talked about the collective groan that everybody experiences when, oh man, there's somebody that's suicidal, and we have to put all this labor or whatever into this person. And then I'm thinking about what Leon was sharing earlier, that some of the physicians maybe they didn't quite see the relevance, or it didn't feel quite comfortable for them to go into that realm. I think it's not a secret that different agencies, different companies, different clinicians, different people are motivated by different things, and I think sometimes we have to figure out what motivates each facility, and it's gonna be different. And for some of us, we're wanting to do the right thing ethically, we're wanting to do the right thing legally or clinically, and then I think there are going to be those of us that we have to hear the horror stories, and so it just takes one or two horrific events that occur in somebody's inpatient facility, or that occur with a patient that you just saw. You're an internal medicine physician, somebody just came in, and then
or Andrew, or a colleague who's lost a child,
or colleague, or it's some people, I hate to say, need to be scared into doing it, but the statistics are staggering. The research is out there and it's widely accessible, and so I think a lot of it is educating people, and if it happens to scare them into doing the right thing, I think they need to hear it. It's not like it's being made up. So.
Michael, you had a comment?
Oh, sorry. I think with creating a culture change, it's important to create a shared need. And what occurred to me when Dr. Love was talking about being admitted to the emergency department right now is the first question is about Ebola. And it seemed that we as a community and even as a nation created a response to how to screen for Ebola in healthcare, basically
overnight. We did it overnight. Based on fear, you should have been screened for getting struck by lightning.
And how many people have died by suicide in that time since died by Ebola? And can we use any lessons learned in that process to think about how serious this is for our county and our community?
Exactly. Michael, you had a comment?
I just think that's a terrific point, so thank you for making it. I just want to also to add that from kind of a system of care and community overview, there are some examples of very successful initiatives in other areas around the country. I don't know exactly how they interface with this, and perhaps you can enlighten us, but where really communities have made commitments to never suicides as tremendous aspirational goals. And believe it or not, when a community comes together and shares a foundation and a dream and all a collective set of resources, incredible things can actually really happen. So I won't call out by name who has done this, but we have seen reductions 50, 60% upwards for these systems and communities. And here locally, inspired by this, the Board of Supervisors and Community Mental Health and Behavioral Health, along with other stakeholders, CHIP, the Suicide Prevention Council, our Medical Examiner's Office, various systems of care, similar to our efforts around Alzheimer's and heart disease, we're going to be convening, and we'll be hearing more about this coming up over the next few months into the next year, a really broad initiative bringing together and hopefully to really carry on the work that we're starting and the discussions that we're starting here. So if there is some hope that I'd like to provide, it is that there will be continued venues for this very important discussion.
My name is Mike Wilson. I'm an emergency medicine physician at UCSD. So with that and the fact that I actually had a late night shift last night, please forgive the impertinent question. But the question is this, I can't escape the feeling as we talk here that we've been we've been asking sort of the wrong questions, and I'll kind of, with my ED doc mentality, kind of maybe flesh that out. And the first is, and I have this on my phone here, the U.S. Preventative Services Task Force, as recently as last May, did a fairly exhaustive review of the literature and concluded that they couldn't say much about the risks versus harms of screening for suicide. Now, I want to contrast that with another piece of research, which I'm sure most people in here are very familiar with, and that's the Luxton article from 2013, which was a systematic review of methods or things to bridge the gap between the emergency department and follow-up. And they found moderate to good evidence that things like carrying contacts, and I see Dr. Posner nodding, right, that carrying contacts actually matter quite a bit. So my question is this. I would suggest, given that we have pretty good evidence that stuff after the emergency department matters, and we don't have a lot of evidence that screening before the emergency department does, maybe we should have things like carrying contacts first aid. Maybe CHIP should be involved in bridge programs, suicide hotlines, contacting folks, creating systems of care once they leave the trauma bay. I'm wondering if our panelists can comment on any of that.
Well, let me ask the panelists, and Dr. Posner in particular, don't we need the whole toolbox? This is just one tool. We need the whole toolbox here.
For sure, and a lot of very, very wise people who have been thinking about this for a long time, from Harvard to the National Action Alliance, have commented on that first study that you talked about, and really, you know, we don't have a lot of good evidence because people have not been systematically screening to really talk about what its meaning is because of everything that I described, and there's some pretty powerful statements about how it would be really silly for us to pay attention to that. But I agree with everything you said. I don't think it's a matter of, well, really, we shouldn't do this, we should talk about that. I think we definitely need the whole toolbox. And I think most of us who work in suicide prevention every day and in these national efforts do believe we have to do it, you know, when they're coming into the door, and then focus on all the other things you said. Like I said, the lack of warm handoff, the lack of safety, all those things are things that in the organizational vision of zero suicide, you know we have to address. So
I just wanted to also add one quick program that, if you're not familiar with it, NAMI San Diego has a program called Friends in the Lobby, which I think hits right on what you're talking about. It's a program where volunteers are there in the waiting rooms, working with the families, working with the people as they're getting discharged. So please do some research on it. But it started here in San Diego. We'd love to replicate it around the country.
So just some closing remarks right here. I have Executive Director, Yellow Ribbon Suicide Prevention Program, Carol Skilgen. She's also co-chair, San Diego County Suicide Prevention Council, for some closing remarks.
Well, we are in the afternoon, and I realize that it's only me between lunch and or your weekend. But so I'm just really truncating the what I wanted to say. But in particular, I do want everyone to understand that one of the ways that the Suicide Prevention Council was formed in San Diego County was because of money from the Mental Health Services Act that was targeted. Each county got money specifically for suicide prevention. So because we had, CHIP had been doing the work, I know this was mentioned earlier, via a suicide prevention work team, the county took advantage of putting out an RFP to find out, okay, would somebody like to, to sort of champion this work? And so, of course, CHIP applied and got it. And so out of that came something, an activity that we needed to do, which was to create a suicide prevention plan. And we had huge stakeholder meetings, a couple of them, a lot of input and stuff. And I think it's very telling that we thought big. I mean, there's a huge cross-sector of people that are still here, thank you, but that have been here today. And that's how it's been pretty much all along. But we have a collaborative, community-wide effort focused on realizing a vision of zero suicides in San Diego County. So, we are, trying to be that beacon saying that, and we so appreciate everything that we've heard today. I do want to say, as far as I'm concerned, this is a milestone. This is, for Dana to say that we've been sort of thinking about this for 2 years, and I know Dana had been trying to do a lot of work, to advance this. We have achieved a milestone today. So with that, I just want to say several thank yous. One, to acknowledge and thank Beth Seiss for her insightful guidance of today's roundtable event. And thanks and gratitude, of course, to Dr. Kelly Posner. Where are you? Oh, okay, maybe you took off already for the ski slopes. And of course, our two wonderful coordinators of the panels, Dr. Nick Infantidis and Dr. Michael Seiss, and especially a big thank you to our panels. So if the panel members are still here, could you stand up? You probably need a stretch anyway, and let us acknowledge you. Please, come on. So this was great to have this kind of conversation today within the context of the larger community. And of course, this wouldn't have happened without our wonderful Suicide Prevention Council staff, Dana Richardson, Yenny Palomino, Elizabeth Vaughn, and our new addition, actually Elizabeth's been snatched by who have you been snatched by? The food people within Church. But Laura Kayanen, is she out there? Okay, so she didn't hear me. All right, so she's already working hard for us. So anyway, you know that the staff's going to be in touch with you. If you please fill out those evaluations and have a great. There's 2 sides to it. Thank you, and I hope you enjoy your weekend.